7 o'clock in the evening. I am really excited to talk to you about clinical trials. It's a strange time to give this talk. Some of you may have recently heard about some trials where some of the data was not what we had hoped. And I think there's right now, a lot of disappointment in people who've heard about that. And I will talk about that today. And hopefully I'll leave you with a lot of hope because there's still a lot of exciting research to be hopeful about in Huntington's disease. So I'm the director of the center at Northwestern, for those of you who don't know me, and I am going to just show you some disclosures. I speak for several pharmaceutical companies, and then I do some consulting work, and I'm on the editorial board of a journal that's listed here. So the objectives of this talk, just before I can really talk about the exciting research, I have to make sure we have kind of a common language and understand about the DNA and proteins and some of kind of the basics of HD. So I'm just going to spend very short time, a few slides, explaining the background of HD and how it's relevant to the research. And then I'm going to talk about 3 different kinds of research: observational studies, which are studies where we learn about the disease in order to later on find ways of curing the disease. I'll talk about symptomatic therapy studies, in particular treatments for symptoms that are classic symptoms of Huntington's, like chorea. And then disease-modifying therapies, which I think is what most people get excited about hearing about, which is studies to actually try and slow down or stop the disease progression. So you probably know that Huntington's disease is a neurological condition. It's a degenerative condition, and it's characterized by this triad of movement problems, cognitive problems, and behavioral psychiatric problems to different degrees in different people. These shared symptoms are inherited and in a pattern that we call autosomal dominant, which means that there's a normal gene and an abnormal gene that everybody gets, and there's a 50-50 chance of passing on the abnormal gene to any offspring, leading to a strong family history component to this condition. And it's, as I mentioned, a degenerative disease in that areas of the brain that control those things like movement and cognition and behavior slowly deteriorate or atrophy or shrink away over time. And you can see the difference between kind of the full normal brain and the atrophied or shrunken changes in areas of the brain in someone with Huntington's disease that occurs over time. So this is probably the most important for understanding the research that we'll talk about towards the end, especially the disease-modifying research, which is basic understanding of how our organs and brain and body work, which is that DNA is the recipe for making the building blocks of our body. DNA is this double helix that is twisted in this way that's shown at the top, and it's untwisted in order to be read. And so it makes a message, which we call the RNA, which is shown as one strand here in green. And so the DNA is untwisted into this message, which is the RNA. And then we have machinery that can read the message and turn it into these building blocks or proteins, which I have shown here. And so Huntington protein is one of those proteins. Huntington protein is an important protein for our brains to function. And when the Huntington protein is not formed properly, that's a problem that leads to damage in the brain and deterioration in the brain. So an example shown below is the protein how it normally looks in the Huntington protein. And then below that is this abnormally elongated stretch where the recipe got mutated and created this protein that was abnormally long. And that protein doesn't function properly. So when we look at therapies, we're going to look at them at different stages along this process. Most of what we're going to talk about is going to be focused on this RNA to protein level but in the end, what we want to try and do is not make this abnormal protein. But setting the stage here is just important to kind of keep this order in mind of DNA to the message, RNA to the protein. So when this abnormal protein gets made, it builds up in cells in the brain, and this is showing you a cell with this blue glob in it, and this blue glob is the mutant Huntington protein. It's abbreviated HTT here, mutant Huntington protein. And it builds up in the cell, and it makes different machinery in the cell not work, and it causes death to the cell. And what's listed there on the right, all those complicated terms are different medical terms for damage that's occurring in the cell. An example is excitotoxicity, which means that the cell gets too active and it causes toxicity. Mitochondrial dysfunction, the mitochondria are the energy producer of the cell, and sort of the energy factory of the cell gets destroyed by these abnormal proteins. There's a term there, apoptosis, which means spontaneous cell suicide or cell death, where because of these proteins, the cell just stops working and dies off. And there's different terms here. They're all different problems that can go wrong in the cell. All of these are different targets for potential therapies. On the small picture on the right, I'm showing you that we can actually see the protein built up. A glob, that black circle in there is inside the neuron. You can see a glob of abnormal protein built up in there that proves that it is actually in those cells. This is the natural changes that we see in HD, is that there's this stage where people are pre-symptomatic for some time, and then there's this prodromal stage where there start to be some minor signs that maybe the symptoms are starting to develop, but they're not obvious yet. They're not definitive enough to make a diagnosis. But there may be some mild cognitive issues, some mild mood changes, some fidgeting. But you can see that then it progresses into what we describe as the early symptomatic stage, and so on. You can see the motor, the cognitive, and the movement problems sort of gradually escalating over those stages. And likewise, on the bottom graph, you can see the changes in the brain occurring gradually over stages where there's loss of volume in different areas of the brain. And so as we start to talk about research, you should have a sense of sort of the hierarchy of the significance of research. At the bottom of this pyramid, the least sophisticated in terms of quality of research is the animal or laboratory studies, or what we call preclinical, that don't involve humans. And these are vital, and we don't really, this is where we start for any drugs that will eventually be developed to cure or stop Huntington's. But it's you can see that we need to escalate from there to higher quality studies at the top of the pyramid, like randomized control studies, which is studies that really rely on reducing our bias and our understanding of whether what we're studying is real or not. And then with drug development, there are different phases, and you've probably heard of these before: phase 1, phase 3. You've probably heard these terms described. And so what those typically refer to is that phase 1 study is very early safety study, and it's focused on how tolerable a drug is, sometimes even in healthy volunteers, sometimes not even in the population that the drug is being studied in, just whether it's safe to even use it. A phase 2 study is a proof of concept of still looking at whether it's safe, but typically in the population of interest, and trying to get some preliminary data on whether it might be effective. And here you're typically looking at 10 to 100 people. A phase 3 study is looking at, does it work? And typically you're looking at that in 100 to thousands of people. And that's typically going to be a randomized control trial, trying to have a placebo group where you can compare it to. And then a phase 4 study is often actually after a drug is approved, following it for longer to learn more about the drug. And there are some studies that are in overlap that may be called a phase 1/2 or phase 2/3. So you may see some overlap between these. So just briefly talking about observational studies, because they shouldn't be neglected, they are important. Observational studies, it's what they sound like. We're not giving patients any treatment, we're watching them. We're learning about the disease. No attempt is really made to affect the outcome. There's no actual intervention, but this is how we learn and to ask the right questions. This is how we generate theories to develop drugs. So what can we learn? I mean, some older observational studies in Huntington's disease, one was called Track HD, and in that we learned about how early can you see changes in the brain? How sensitive are certain areas of the brain to change in response to certain treatments? there was a trial called Predict HD, which again looked at certain areas of the brain and which ones of them changed faster or slower to tell us in the future when we develop drugs, where should we be looking to see change. Enroll HD now has over 20,000 participants worldwide, largest observational study in HD, with a lot of really generous data that can help us ask a lot of great questions. These are just from our own group here at Northwestern, and what we've used Enroll HD to answer. We had questions about age of onset, about use of services like PT and OT, about family history, and we answer these questions using data from Enroll HD. So this is really helpful to the community when people participate in this. Another form of observational studies that we're doing right now that is really relevant right now is telemedicine. You know, a lot of our clinics are a combination of in-person and virtual these days. And we're trying to learn more about how well we can study Huntington's without having to bring people in all the time. And so we're doing a study at Northwestern led by Danielle Larson, who's one of our neurologists. And this is on studying the motor and the non-motor assessments, the examinations that we use, and seeing if they are similar when we do them on video versus when we do them in person, in order to help us better understand how well we can apply this to people far away from us. What I think is the most exciting about the observational work right now is on genetics. So this is a phenomenon that I think is really interesting. People want to know what their repeat length is. And I want to know what my patient's repeat length is also, because we know that the larger repeat lengths are associated often with earlier onset of disease. But I say often, and I say we can't predict the age from the repeat length. We've known this for a long time. But what you can see is, if you look at someone who's got, let's say, 40 repeats, and you look at their age of onset, if you look at where that red line falls, you see the average age of 60. But you see all those little circles around that red line is all the variability that any particular individual may have with 40 repeats. So you can see one person with 40 repeats had onset at age 25 or 30, and one person with 40 repeats had onset at age 82. And that's a huge difference. And that variability goes down a little bit as you get to the larger repeats. You can see that 55 repeats, there's a little less variability, but there is still variability. And so what leads to this? Why would one person with the same number have an older onset and someone have a younger onset? And why that's also important, not just so that we can tell you what to expect and predict, but maybe we can take someone who has 40 repeats, and instead of having them have their disease start when they're 40, could we make it start when they're 80? Could we push it by learning more about why does someone start when they're 80 in the first place? So there's been great work done through Harvard on this, looking at genome wide association. So what they do is they look at blood, they take blood from lots and lots and lots of people with HD, and they find what is similar outside of the HD gene itself. What is similar about the people who present older, and what is similar about the people who present younger than they should based on their number. And they found that there are some areas that stand out. And all of these areas that you see that stand out of these bars that are pointed to with these arrows, these all seem to cluster around people who either had an older than expected or younger than expected onset. And so these are genes that we need to study more about, because they tend to all be involved in repair of mutations, natural repair. So we all have genes that are naturally there to repair mutations that are always going on in our DNA at all times. All of us actually have mutations going on in our DNA even after we're born. And we have genes that protect us and repair those mutations. And these other genes that turned out to be related to those repair mechanisms, and they may be important in the future in our research. I'll come back to this. This got some attention a few last year or 2 years ago, is that when we count the repeats, sometimes we don't realize that some of the repeats are actually not the same. So we count the CAG repeats, but sometimes in the middle of those CAGs is a CAA. And a CAA and a CAG, we can't really tell the difference between them in terms of what they do, but it may be that when we see these interruptions in this string of CAGs, that these interruptions perhaps are an opportunity for repair to occur. This is a theory. And in that, we find that people who have more of these interruptions in their CAGs, maybe they have an older age of onset because they have these interruptions. These are things we hadn't accounted for before. So just another way that observation has led to theories that may eventually lead to drugs targeting ways of slowing down disease progression. I'm going to come back to slowing down disease progression. I want to pause first and talk about symptomatic therapies, because we have to take account of the fact that when we're talking about drugs that will cure the disease, we are talking about the future, but a lot of people are dealing with symptoms today, and we need good treatments to deal with day-to-day symptoms also. A lot of that is dopamine related. We know that movements themselves are increased in people with Huntington's, that they move too much. And a lot of excessive movement is driven by excessive dopamine signaling, which is a chemical in our brain that signals for movements to occur. So one of the ways that we're effective at treating the excessive movements is by reducing the dopamine or depleting the dopamine. This is shown here. Dopamine is in these pink bubbles, and it's being released into this what we call a synapse. Dopamine is released, and then it binds on the other end, and it causes a movement to happen. Well, the drugs that we've been using to reduce this, what they do is they block the packaging of dopamine so that then you don't release as much of it. And by not releasing as much dopamine, you don't cause as much movement to happen. So we have FDA-approved drugs that do this. There are 2 FDA-approved drugs for Huntington's chorea so far. Chorea is the name for that excessive movement. One is xenazine, and another is Austedo. And they're very similar in the way they appear, showing their shape here between the two. They're related to each other in how they function. And then importantly, there is another drug being studied right now. The study is being conducted by the Huntington Study Group. The study is called Connect HD, and they're trying to recruit 120 people who have chorea, who are to get this drug to reduce their chorea. This would be, if this ends up being effective, would be then a third drug to treat the abnormal movements. This is actively recruiting, and people are desperately needed for this study. This is one of the few studies in Huntington's that is underperforming in terms of recruitment. It's a drug that I think is going to be one that we're going to be very interested in and excited about. It's a drug that we already use for a different condition. And I would say that when I use it for that other condition, I'm very happy with how it works. And so I'm excited to see this drug move forward. But it's only for people who have chorea who are not already being treated for their chorea. And so it's been a little slow to recruit. So if you or anybody you know has abnormal movements with Huntington's and is not currently being treated for those abnormal movements, then you may be eligible for this study. And I think nationwide, there's only about 70 people that are in it. So we still need about 50 more people. And we're recruiting for this at Northwestern as well. This is just showing the data from the existing drug Austedo or deutetrabenazine, showing how it improved the abnormal movement score, the chorea score. The placebo group is at the top. The deutetrabenazine or Austedo group is on the bottom. And you can see the difference, the separation from placebo, where lower scores are better. And you can see the lower numbers separating from the placebo. This is at 12 weeks in the group that got the treatment. So just showing the size of the effect. But there are other symptoms that we have, I think, not paid enough attention to. And I think there are companies now starting to pay more attention to some of the non-motor symptoms too. So irritability. Now we do have psychiatric medications that are effective for treating a lot of the symptoms in HD, but irritability is a tough one. And Azavan Pharmaceuticals has been working on a drug that works more, instead of working on psychiatric receptors as antipsychotics do, they're focusing more on a hormone receptor called vasopressin. And they conducted a study, which we participated in at Northwestern as a phase 2 study, which showed that they were able to reduce the frequency of aggressive outbursts compared to placebo. But this was a small study. I mentioned phase 2 studies are these studies that are usually in like 10 to 100 people. So it met their tolerability and safety parameters. And the plan is eventually to move forward with a phase 3 trial, which I hope will happen soon. Cognition is probably the most disturbing and distressing, is that everybody with HD develops dementia over time. Dementia, we don't have good treatments for in any condition in neurology with regard to Parkinson's disease, with regard to Alzheimer's disease. Dementia is an unmet need. And so a company called Sage is working on a drug. This drug works on a specific receptor in the brain called the NMDA receptor. The NMDA receptor is a receptor in the brain that affects excitability of the brain. And there's a particular component of this receptor that was shown to be lower levels in people with early Huntington's disease. And so this company is working on developing a drug that is an oral medication, a pill, that would increase the activity of that component of that receptor. And they had a phase 1 study, remember that's the earliest phase kind of human studies, that showed improvement in problem solving and improvement in memory. Now, phase 1 studies don't have a placebo group, they're not controlled studies, but at least it's a signal that they want to move forward with a phase 2 study to see if this will improve problem solving, memory, thinking in people with Huntington's disease. So now what I think most people are waiting to hear more about, which is the disease modifying therapies. And what is disease modifying? If you remember the graph that I showed you showing the natural trajectory from pre-symptomatic to prodromal, early, moderate, advanced disease, we want to shift that graph. We want it to stop ideally, but what we're really looking for in the short term with the trials that we're doing now are, can we at least change the curve a little? Can we change the curve to be not as steep? And have progression be slower, ideally reverse, but we're really trying to make it slow down. And I showed you this cell and all the different components of the cell where we might target to try and protect a cell from damage. So some of the studies we're going to look at are how do we protect the different structures in the cell against damage. And some of the trials are going to focus on the protein itself, that blue glob of mutant Huntington protein. How do we prevent it from forming in the cell in the first place? So we had some early failures with trying to protect the cell. I call these non-targeted therapies because they're not focused on the gene, on the DNA or the message or the RNA or on the Huntington protein itself, but they're focused on the inflammation in the cell and on the damage in the cell, and so indirectly trying to help the disease. And so we had some early failures with coenzyme Q10 and creatine as ways of protecting cells. More recently, some of these non-targeted therapies, one was one that you may have heard of over the last few years, was Vaccinax or Signal. This is a drug called Pradopadine. And a lot of participants in this study, they were going through monthly IV treatments of this drug, which reduces inflammation in the brain. This particular target causes the cell skeleton to get damaged, and it causes inflammation in the brain. And they were trying to block that process from happening. And so they recruited people who were early symptomatic, but also they were unique in that they recruited people who were in the prodromal phase too, so even earlier. Unfortunately, they announced a few months ago, or maybe it was last year, that the treatment group was not significantly better than the placebo group on what they had required as the endpoint. One of those endpoints was the impression of change that the clinician had, and they had some other endpoints. It was the safety and tolerability was good in the trial. They did meet that endpoint. But that may not be the end of their story. Remember, they decided on these endpoints ahead of time, and they didn't meet those endpoints. However, they did have a suggestion that the drug might have improved metabolic activity in the brain in certain areas that are associated with cognitive decline. And so going to this is an example of a PET scan showing different areas lighting up. Areas of the brain that are more active or less active will light up to different degrees. And they saw differences. In red is the placebo group, and in blue is the treatment group, the group that got the drug, Pradopadine. And you can see a clear separation, the blue on the right and the red on the left, of different areas of the brain and how they lit up. And so this raised the question of, even though they didn't meet their main required endpoint, is this somehow affecting the way the brain is functioning? And may that have an effect on cognitive decline? Should they have looked at different endpoints? Should they have chosen different patients? These are all questions that I think, are still asking. And I don't think that this is the end of the papinimab story. So I think we may see more out of them based on this. But right now, that is where that one has been left publicly, at least. One drug that is actively being studied now is Pradopadine. So this is another one that doesn't target the Huntington's disease gene itself, but is trying to protect cells. And so it's a pill, it's an oral medication that is meant to stabilize and protect cells against stress and inflammation. And it was already studied in a phase 2 study. And unfortunately, it did not show improvement in movement compared to a placebo group, which is what they were looking at. By stabilizing cells that are involved in dopamine, they were hoping it would improve movement. Now, the placebo group had a big positive effect, which may have hurt the trial. But nevertheless, it was not going to move forward in looking at improvement in movement. However, one of the things that they looked at was functional capacity. This is a scale on the right of functional capacity. How well can you be independent in working, in doing your finances, in doing chores around the house, day-to-day activities? How much care do you need? And on this scale, they did see a difference compared to placebo. They saw a 1-point improvement in the group that got Pradopadine compared to a slight worsening in the placebo group, which is what you would expect just naturally, is that people get a little worse on this scale over time. And so based on that, they are proceeding now with a phase 3 trial to see if this is a drug that legitimately slows down the functional decline in people with Huntington's. So we are actively recruiting for this trial. It's an oral medication being compared to a placebo. And we have people being screened for this right now. This is for it's a phase 3 trial for early symptomatic patients with Huntington's. 480 patients are going to be recruited across 30 sites. Again, actively recruiting. So now talking about the targeted therapies. These are the ones that lower the mutant Huntington protein. And we're again going to show you this graph of DNA is that basic recipe. It's turned into a message, the RNA, and then the message gets turned into the Huntington protein. So where along that pathway can we achieve not getting the Huntington protein? So this looks a little bit daunting, but just bear with me here. This is showing you this green, by the way, is my mouse showing, Emma? Yes, please. Okay. So this green glob is the mutant Huntington protein that's being made. So if we back up, what you can see is the DNA will make the RNA, the message. The message is this pink string here. The message then will turn into the protein here. But what we want to do is we naturally have these little Pac-Man-like creatures. If you remember Pac-Man, the arcade game that eats all those dots. That's what these red and yellow things are, like our own internal Pac-Man that eats up everything. So what we can do is we can bind to this message something that the Pac-Man is attracted to, and then it'll eat it up before it can make the protein. So that was the goal of a lot of the trials that have been going on or are going on. On the left here, you see the spinal tap injecting a treatment through the spinal fluid that would then bind to this message and make the Pac-Man eat it up before it makes the protein. On the right, what you're seeing is a virus that's delivered directly into the brain that then allows you to make your own message to bind and make the Pac-Man again eat it up. So two different ways, two different approaches, two different targets, one through the spinal fluid, one directly into the brain, of ways of connecting onto that message to make it get eaten up before it can make the protein. So focusing on the one that goes through the spinal fluid, these are called Antisense Oligonucleotides, or ASOs, the two companies you've probably heard named Roche and Wavelife. And they both had approaches that were very similar in this regard. Again, shown here again, just to hammer this in, the DNA gets untwisted. It turns into a single strand that can be read, but then you inject something that binds to that so that it can't be read and it can't make the protein. So what happened here? Recently, there were two press releases, one from Roche and one from WaveLife, announcing that they were not successful after the last 2 years of phase 2 and phase 3 trials in humans, in people with HD. So Roche had no major safety concerns, and they said that they stopped due to lack of evidence for the benefit-risk ratio when compared to placebo. They haven't shared the data yet, so I don't have that data and I can't share that with you. It's not been made public yet, but they did make this announcement public. So what this means was they didn't stop it because it was harming people or that it was unsafe, but they stopped it because they didn't see a reasonable benefit to putting people through these procedures based on the data compared to the group that was getting a placebo. Whether that means that the group that received the drug did worse than the placebo, we don't know. But they didn't see the benefit that would qualify people to continue getting these procedures done. Now, the trial is not over. The administering of the drug is over, but people are still participating in the trial for the sake of data collection. I will say this is probably some of the most valuable data. This is not a lost time. This is probably some of the most valuable data we will ever have in Huntington's, because we have spinal fluid data and blood data and MRIs and all sorts of great information. But it's really disappointing, certainly, that this was the farthest along of these Huntington lowering therapies that was unsuccessful, and we have to ask why. And I'm gonna go into that. WaveLife then came out and said that they did not achieve significant lowering of Huntington protein with two different drugs that they were studying. Their drugs work like having GPS targets on the messenger RNA. And they had two different ones that had two different GPS targets, and they're going to stop both of those now. However, they're not done either. They're going to proceed with a third one that has a more refined target that uses GPS on a different part of the message, and they hope that that is going to work better. So they are still planning to proceed with a third drug, even though the first two are being stopped. So the thank you here is not, I'm not ending my talk yet. The thank you here is for the participants. You know, I have 8 of my patients in my own practice who participated in this trial. There's a lot of work for them coming in, getting these spinal taps, blood work. You know, it really is the Olympics of studies when we choose people who can handle going through all of this, coming in every other month for these treatments. And I really don't think that they wasted their time. I think we are going to learn so much from this data. And I think hopefully we'll learn about why this was not successful, though. So I think disappointment, but not despair, is the message that I would take from this, and questions we need to ask from it. And I've highlighted a few that I'm going to talk about. I wasn't going to talk specifically about this, but is the mutant Huntington protein the right target? I think the answer is still yes. I think we are in agreement as a community in research and in the clinic that the mutant protein is the problem. And I don't think that that's the wrong focus. There is this question you may have heard about the wild type protein versus the mutant. Some of these drugs are reducing the normal one as well as the mutated one. And there's a question about whether that's a problem. And that's a bigger question than I can answer in the time I have here. So I'm happy to address that if people have questions about that at the end. But what about, is it possible that we're going to miss out on drugs that work because our measures aren't right, or we're choosing the wrong people to study it in, or that the route of administration is the problem? Is the ASO a good strategy? Are there better ways of reducing the mutant protein? And should we look outside of the HD gene? So I'm going to try and address some of these questions. So how are our measures? Are we able to tell if we're being successful is my question here. So the mutant Huntington protein can be measured. We know that there was a study that showed that it actually increases. There's more mutant protein over time. So people who don't have Huntington don't have it. When they get into early stages, they have more protein. When they get into late stages, they have even more of this protein. So there is some data to suggest that we can measure it, and that more of it shows that the disease is worse. There's also data to suggest that the drug, so this is data from actually the Roche phase 2 study, that when the drug is administered through the spinal fluid and we measure the mutant protein, we can actually see improvement in the mutant protein. This was from their phase 2 study. Now, I don't yet know if their phase 3 study that just ended, that just got discontinued with the drug, whether they replicated this or not. So we'll find out. If they did not replicate this in the phase 3 study, then that will be concerning. If they did replicate it and it still is not moving forward, that tells us that potentially that this is not a good measure for us to tell if a drug is working. So there are going to be a lot of questions once we see this, but you can see that you can measure it. But should we think about other measures? I mean, one question I have when I look at this is we're measuring it in the spinal fluid, but the problem is in the brain. And so the spinal fluid is the closest we can get to that, but maybe that's not a good measure of what's really happening in the brain. And that's something we have to figure out. Is there a better way to measure what's going on in the brain? CHDI is working on scans of the brain that might be able to measure mutant huntingtin in the brain. That would be really exciting if we had ways of using like heat maps of the brain, like I showed you before with the PET scans, that could tell us if mutant huntingtin protein was more or less active in different areas. So these imaging markers might be a future option, which is being studied. What about the question about who are the right people? Now, this is a tough question because I want to, if there's a drug that might work, I know we want everybody to be on it. And the problem, though, is it possible that a drug might work better in people who don't have as much burden of disease in their brain? And is it possible that when we're choosing people, we need to choose them at the earliest sign, even before they get symptoms, in order to be able to be effective in preventing the disease progression? Now, the problem there is if you choose people who don't have any symptoms, you might have to follow them for 30 years before they get symptoms in order to know if the drug is working. And so that's why we're often choosing people who have early symptoms, because we know we can follow them. If we had better ways of telling if the disease was changing, we might be able to test people who don't have symptoms yet. And maybe that's when we're going to be able to find solutions that are more effective. Maybe we are starting too late with some of these trials. Again, these are just questions that we need to ask, but it's also frustrating. I know when people say, why can't I qualify for a trial? It's not necessarily because a drug wouldn't necessarily be effective for you. It may be just because we may be less likely to be able to tell in a short enough period of time to get a drug through and onto the market. What about the best route of administration? I mentioned there may be some limitations to spinal taps and spinal injections. Maybe that's not direct enough. And so some of the drugs that are being studied, I showed you earlier, are being developed directly to go into the brain. So this is called RNA interference, that the injection is happening through a surgery to go directly into the brain. A virus then sends the message to create a protein that blocks the formation of the mutant huntingtin. So this is AMT-130, or Unicure. You may have heard of this. This is an ongoing trial. First, they did some animal work in mini pigs and monkeys, and they showed that they could infuse it into a specific target in the brain with good safety in those animals. And they were able to reduce the mutant huntingtin protein in the animals. So now they are embarking actively on a phase 1/2. So remember, that's the early kind of studies. These are done in small numbers of people to see if it's safe and tolerable. They are doing it in a double-blind fashion, where some people are getting an imitation surgery. There are 26 people. So I showed you phase 1 studies are small numbers of people. And they're going to try to deliver it directly into certain structures in the brain that we know are most affected in Huntington's. And they're going to follow people for their main outcome at about 1.5 years, and they're going to keep following them for 5 years. They're looking again at early symptomatic people, and they're trying to target 50 to 75% reduction of the huntingtin protein. So they began in June of 2020. They recruited their first 10 people. 6 of them got the drug and 4 got the placebo. It's really slow because it's a small number of people, but also they want to wait a certain amount of time, months between people, to make sure it's safe before they go on to the next person, because this is serious, it's brain surgery. The next group of 16 people will be recruited soon. And then they announced that they're going to open an open label, meaning no placebo, no sham surgery in Europe, with 15 people there. So far, knock on wood, there have been no dangerous safety concerns reported. And then another company, Voyager, is going to be starting their trial soon as well. Some differences in terms of which target in the brain they're using, but the overall idea is similar. The designs of the trials are a little bit different. And that one is going to be, we're hoping for fall or winter of this year. What about, are there better ways to lower the mutant Huntington protein? So both the spinal infusion version and the one that goes into the brain, they're both trying to lower the Huntington protein by blocking that messenger RNA from making the protein. And that is shown in this complicated diagram here. The top of it is what we were just talking about. It's binding to the message and then making that little Pac-Man that we have in our bodies eat it up before it can make the protein. But there's other areas we could focus on. We could focus on the DNA, which is the parent of all of this, the beginning of all this. Could we focus on that part? There's also other ways to focus on the RNA, on the message, and I'm gonna talk about that briefly. So you'll hear about splicing. This is a new topic that's being discussed a lot in Huntington's research. So I'm showing you, what I'm showing you at the top is something that normally happens in our bodies all the time. So our DNA has parts that are read and parts that are not read. The parts that we read are called exons because they are expressed. That's where the word exon comes from. And in between them, there's sort of not important stretches that get cut out. And so a splicing process is naturally occurring all the time to cut out the stuff that we don't need and then merge together the part that we do need to read. And this happens with the Huntington's gene too, like every other part of our DNA. So you can see here the exons, which are the parts that are going to be read. They're in the middle part called the intron gets cut out or spliced, and then everything gets glued together. So this is naturally happening in normal genes, and it's naturally happening in the mutant Huntington gene also. So one thing that is being looked at, and so when you get that, so that editing happens at the top, you can see then the mutant Huntington protein is made. So a couple companies are working on some really exciting work with oral medications, again, pills, non-invasive. PTC Therapeutics and Novartis are two examples of these companies. Where they will insert in this part that's normally cut out, they will insert a code that has a stop sign in it. And when that part gets cut out, it's now going to have a stop inserted in it. And so rather than being able to cut it out and merge it together and make the protein, it's going to insert a stop sign so that it doesn't make the protein in the first place. So just a different way of trying to get us to not make that mutant Huntington protein. But it's exciting, particularly not just because it's a different way of doing it, but because it's also oral medication, which would to me suggest that it will get hopefully everywhere. They'll have to prove that, but instead of being just in the spinal fluid, if it's oral and digested, maybe it will get everywhere in the body. So oral small molecule splicing modulators, that's why they're called splicing modulators, because they affect the way it's edited there, to reduce the level of the mutant Huntington protein. So both companies, Novartis and PTC, have reduced levels of the protein in animal models throughout the body of the animal. Novartis has a drug it's called branaplam, and it's been shown to reduce the mutant Huntington protein in people as well. So it's interesting, they use this drug already for a different disease called spinal muscular atrophy, or SMA. And in studying that group of people, they happened to look at their Huntington protein levels just to see if it was affecting that. And they found that in this group of people who doesn't have Huntington's, they were able to reduce their Huntington protein levels. And so now they're planning a phase 2 study in people with Huntington's. And then lastly, and I'm not going to talk about this a lot, but should our focus be outside of the RNA or the protein, which leaves really the DNA and other genes outside of the Huntington's gene. So I'll bring you back to this. Remember I talked about when we looked at genes outside of the Huntington's gene in other areas, we found that there were genes that were on different chromosomes that led to people having an earlier or a later onset of disease. One example is this MSH3 gene, for example. This MSH3 gene has a lower, when it's at a lower expansion, is associated with a later age of onset and a slower progression. So that's why it kind of stood out, is when they found that certain people who were older than expected, they had, a lot of them had a lower expansion of this gene, which is not part of the Huntington's gene. So we're looking at different areas that tend to be related to DNA repair or DNA damage response. And there's a company called Triplet Therapeutics, which is specifically looking at how do we target these other genes, not focusing on the Huntington's gene, but on these DNA damage response genes and affect the way they are expressed to make people have a later onset of disease. And then lastly, focusing on not on the RNA, but on the DNA, this is very much preclinical, meaning still looking at not human phases of research, but very interesting and exciting is CRISPR, which is gene editing, actually like cutting out the abnormal mutation and getting rid of it before it can make the message. This is complicated for many safety reasons and, for instance, concerns about if we were just to give this to people, would it cut out other parts of their DNA that we don't want it to cut out? And it's complicated to prevent that from happening. And so this is something that's still being studied in animal phases, but maybe something that we look at in the future. So with that, I know there was a lot of science. I'm going to try and just summarize the take-home points. So observational studies first, those are important to our understanding of Huntington's disease and ways to measure changes in Huntington's and the impact of our treatments in Huntington's all come from observational studies. So we're learning in particular more about the complexities of genetics of Huntington's. We had been very focused on the Huntington's gene, but we're learning about variability and potentially new targets for drug development as we think just outside of the Huntington's gene also. And then symptom therapies are in development for chorea, for irritability, for cognition, and other important aspects of quality of life related to Huntington's disease. Connect HD is actively recruiting for chorea. The ASO trial, recent failures are disappointing, but the mutant Huntington lowering story is not over at all. There are still active trials going on with AMT 130. There's other companies that are developing ones that go directly into the brain. Even some of the companies working on the intraspinal fluid are not done with what they're going to be doing. And then there are oral small molecule trials in development, including Novartis and PTC. And then there's interest in slowing progression of disease by focusing outside of the Huntington's disease gene as well. And so if you're interested in learning more about trials, obviously talk to me, talk to your neurologist at your Huntington Center, look at HD Trial Finder, clinicaltrials.gov. Those are good sites to look at. This is from a slide from Dr. Leora Fox from HDSA, which just gives you you're meant to be a little bit overwhelmed by this to show you all the companies in the space of this is just mutant Huntington lowering development. And then, even more if you look outside of just mutant Huntington lowering at other aspects of the disease and that are being targeted. So with that, I'm gonna thank you for your attention and I'm happy to take some questions if there are any.
Does anyone have any questions?
Why didn't he say anything about the proof study?
I have a question because you mentioned that Wave was moving on to try to start a new study with a different medication. Would that be starting in a stage 2? Would they then be starting, so they go backwards to be in a safety trial with
the existing Wave trial is actually a phase 2 trial too. It wasn't a phase 3 yet, the way Roche was. So they're the 2 existing ones that they've stopped were sort of late phase 2. And so this third one is also phase 2.
Okay. And then do you think the COVID vaccine and like new treatments with mRNA, do you think that will impact HD studies? Is there any correlation, I think, between what's going on with the COVID vaccine and research in HD?
I don't think so. I mean, we were all worried that it was going to affect the results of trials, and in terms of, we did have across the country there were more missed visits, and in terms of our ability to be consistent with our treatments. And I think we've minimized that to a good extent. I mean, I know at our site, we barely missed any visits, even during the peak of the pandemic. I think it's probably unlikely that affected the results of the trials too much. I think for inclusion into trials because of receiving vaccines and things, I really don't see a reason that will be a problem. And it's not currently an exclusion for participation in any of the trials that I'm aware of. Actually, every trial has allowed people to get any kind of vaccine and still not be affected by inclusion in their trials.
I have a question. Were any of the ones that you talked about today different code names for the proof
Yes.
trial?
Yes.
When is that?
Yes, I'll go back to it. The proof trial is the Pradopadine one.
Oh, Pradopadine, thank you.
That's this one. That's the one that's looking at trying to slow down functional decline, where they showed in the phase 2 trial, they showed the 1-point improvement compared to the placebo group that got a little worse. And so this is the phase 3 trial that is actively recruiting. It's called Proof. Yes.
Great, thank you. I thought it was one of them. I just couldn't keep them together. I do, and another question, you had mentioned the Connect HD that you were actively recruiting. What range of symptoms are you looking for on that particular one?
Yeah, so for
symptomatic?
Yeah, so the main symptomatic criteria is chorea, which is this is a drug to try and reduce the abnormal movements. So there's a severity of chorea. We do a rating scale, and it has to exceed a certain severity, which is in this case 20, which doesn't mean a lot, which I'm sure doesn't mean anything to you in terms of the number. But I would say think of it as sort of moderate severity chorea. In basically, it should be chorea that is noticeable to the person and to some degree bothersome. It should be at least a little bothersome to the person.
Okay, thank you. I was a little worried that the person I have in mind might be have too much chorea for it, but
no, too much would not be a problem. The main exclusion that the main reason we're seeing people not get in is, unfortunately, they are not allowing people in who are on other chorea medications or for some reason antipsychotics, which a lot of people with HD are on for psychiatric purposes.
Ding, ding. Yeah.
And unfortunately, because antipsychotics can also help chorea, they don't want people in the trial who are on antipsychotics because it will cloud their view of how it's helping their chorea.
Okay, thank you. That was that answers that. I appreciate that. I had one other, but I'll give others a chance.
Does anyone else have any questions?
Hi, I do have one question. Can you hear me okay?
Yes.
Okay, thank you, Dr. Bega. That was really informative. It seems like there are several opportunities for patients with early onset. How do we determine what is going to be the best trial for that person? Is it consulting with your research team? Or what is the next step with that after having an assessment? So my husband, for example, has had initial assessments and looking now to be able to get him involved in a clinical trial if possible, but I see that there's different options. So I want to make sure that we are able to select the best option for him.
Yeah, that's a great question because sometimes participating in one will exclude you from others.
Exactly.
And that's not always true. And it turns out, for instance, people who participated in the Roche ASO trial are probably still going to be eligible for future trials if they, if the timing is right. But in general, you have to think about it's probably for the disease modifying trials, the gene therapies, those sorts of things, especially the surgical ones, it's probably the only trial that you would do because after that, it probably will exclude you from other trials. So some of it is opportunity. These trials are slow in starting up and in recruiting, and sometimes it's like being in the right place at the right time. And if you go too long, you may lose your opportunity to be in one, and then you may not be eligible for another. So sometimes you just have to take the opportunities that you have. I do think you need to talk to your neurologist about what they believe in terms of, what they think is more or less likely to be effective. I do tell my patients when I think there are trials that I'm less excited about or more excited about personally, just in terms of what I think is more or less likely to work. Although obviously I can be wrong, but I could at least give them my opinion about that. Then there's the inclusion exclusion criteria. I mean, sometimes that's the best way that we end up guiding people is, unfortunately, even though you're early symptomatic, there may be other factors that exclude you from this. And so you might as well do this because you can't do both. The criteria tend to be, sometimes they seem a bit arbitrary to us. Like, for instance, the Proof HD trial is requiring that people have some motor symptoms, even though they're not looking at motor symptoms as what they're trying to improve on. And so it's, if you don't have motor symptoms, you're excluded from that. So it's sometimes it's things you don't think about intuitively as a reason why someone might get excluded. Another example is with the brain surgery trials. Even if someone is early symptomatic, a lot of times they're getting excluded because the size of the structure in the brain may be too small. There's no way to know if someone is going to have a small area of that particular part of the brain, but if it's not a good target, they get excluded. And so sometimes you have to get screened and find out if maybe that part of the brain is going to exclude you from the study. I would say if you're eligible and you have the opportunity, at least get screened. Remembering that with any trial, you can always say no before it happens, of course, before you have the brain surgery, before you have the spinal procedure. You can always, after you're screened, you still have the opportunity to say, you know what, I changed my mind, I don't want to do this. But you could make that decision after you find out if you're eligible. And the only way to know if you're eligible is to get screened.
Right. Okay.
I just wanted to add that if you are in Chicago, or if you're a patient at Northwestern or a patient at Rush, our community is really good about like we want you to get into any research study that you're eligible for. So you don't have to be a patient at our site or vice versa to access research. You can also, if there's a study in another state, they will probably pay for you to get transportation and hotels and things like that. So don't be afraid to try to get into studies that aren't near you or at the site where you're getting treatment, because they will make it, if you qualify to get into the study, you will be able to get into it regardless. So you can move between centers and cities to access research.
Yeah.
Thank you.
And I've done that. I've sent my own patients to Vanderbilt. I've sent my own patients to Rush, and vice versa. They've sent their patients to us. And I mean, it's really just about, we don't think of this as a study that's part of our site. We want these studies to go through as quickly as possible and to recruit as fast as possible, because we want to get the information out to the whole community for the good of the community.
Mimi, did you want to ask another question?
Yeah, so my other question is really more about later state and any trials related to that. So if there's anything that's compassionate care or really targeted somebody in their 10th or plus year of career. You had mentioned, I was intrigued when you said, maybe we're not looking at the right people, because if things work on somebody who has very few motor issues, but you have someone flailing, are there things targeted for that really late stage?
Most of the studies that are happening in late stage are more quality of life focused than disease focused. For instance, looking at factors that affect cognition, irritability, specific symptoms, or caregiver burden, or those sorts of things. It's difficult to do very intensive trials in people who have advanced disease for issues of, first of all, complying with the very difficult. Some of these visits are 4 or 5 hours long.
Yeah.
It's pretty typical actually for a study visit to be like a 5-hour visit
Yep.
with blood draws and assessments and everything. So there's that. There's the consenting itself, which is difficult if someone has more cognitive issues. And then there's a question about just the theory of, I mentioned this before, is it possible, and I'm not saying this is the case, but is it possible that once a certain burden of disease has occurred, that we can't fix it, that we can't remedy it? And I hope that's not the case. But if it is, that's where logically we'd want to say, let's try and get it before it does its damage, because maybe that's where we're going to make we're most likely to be able to affect the disease. I think there is some concern about that, is if you've lost certain structures, we don't think that any of these interventions are going to make them come back. So we're trying to slow down loss. But if there is a lot of, let's say there's a lot of Huntington protein built up, even in the cells of the brain that are still there, maybe they already have a burden of disease that's too much to overcome. And so we don't know if that's a problem or not.
Yeah. Yep. And in fact, that was a situation that occurred in terms of getting agreement for, I forget, Roche a while ago. Is, she was right on that edge. But anyway, I thought you might, we're looking for options.
From a compassionate use standpoint, when drugs finally do, I think that's where that's going to be important, though. If one of these drugs in the coming years is effective and comes out on the market, we're going to need to push for people who were not studied, people who are more advanced or less advanced than the people who were studied, to make sure they can get it too, because that's where, why not? What's the harm in trying it? And I think I'm hoping we have that problem. That means we have a drug that is effective. But
Yep. Absolutely. Thank you.
Does anyone else have any questions? Well, we're going to have this on our website and on Facebook, and feel free to share it with everybody, because I feel Dr. Bega shared a lot of information about studies that you probably didn't know were coming down the pike. And I think it's really important for our community to know that just because one thing changed, that there's not a lot of stuff coming up. And I think it's hard, that information is harder to access. So it's good to have it here.
Thank you. We certainly appreciate it.
Yeah. Thank you for coming. Thank you, Dr. Bega.
Yes, thank you, Dr. Bega and Emily, both of you, for your time.
my pleasure. Take care.
Thank
Yeah.
you.
Thank
Bye-bye.
you, everybody. Thanks for coming.
Take
Thanks
care.
for being here.